let's see the next chapter. We have hematological. You know what's going to be big in this one, right? What do you think? It is going to be anemias, right? And so when we think about this, let's take a little journey through some of the indices that you probably remember so very well, right? MCV, looking at MCV looks at the size of the cell, and that gives you the perspective. 80 to 100 is normal, and macrocytic. Your color, how much hemoglobin do you have? Your MCHC is really, you know what? We don't really have hyperchromic in anemia, right? But there is a state called hyperchromia. Mainly, you're going to see the normochromic and the hypochromic. And then we've got MCH, which is looking at the RBC count. Anemia, RBC count is low. Therefore, it kind of moves. It's not as useful. But you got this thing called RDW. Y'all looking at your RDWs when you read your values? RDW means red cell distribution width. It's the variation of cells. The body compensates when you go low with your anemia, and it does what? It makes more cells very quickly, gets them out there in the circulation. And when they get them out there in the circulation, they can be various sizes and shapes. As a matter of fact, as we go through this, some of them are named, so that if you have a particular one that's on your lab slip, it might help you identify what type of anemia you have. There also will tell you a little bit about the differentiates between, now IDA is what? Iron deficiency anemia, thalassemia, and anemia of chronic disease. So in IDA, RDW usually is increased. When you have low iron, your body's going to make more what? Trucks to get the blood circulating around and get the oxygen circulating. Thalassemia is typically normal, slightly increased, and your anemia chronic disease is typically normal RDW. Your retic count, this is an important one. Number of new young RBCs in circulation. Normally it's a percentage, 1 to 2%. It's an index of bone marrow health and the response to anemia. So for instance, it tells you a little bit about whether or not your bone marrow is failing. It tells you a little bit about hemorrhage and hemolysis, and how well your body is responding to therapy, okay? This is going to be evident when I do sickle cell with you. You're going to see that. So let's go into some of the anemias, and we want to think about, again, we're looking at red blood cell count, quality of hemoglobin. We're thinking about anemias are classified. This is a very important concept. Let me have you take a zero in on this one for a minute. This is important, and it's in your notes there very clearly that when you want to think about children, especially those of you who are family nurse practitioners that see kids and adults, you want to think about mainly children or pediatric-oriented anemias are microcytic hypochromic, so they're small cell and they're low color in their hemoglobin. That's your IDA, your thalassemia, lead poisoning. What does lead poisoning create? IDA, iron deficiency anemia. And G6PD deficiency, which is related to diet. Your normocytic normochromics is usually those that are kind of just midline, like your anemia, chronic disease, acute blood loss, early IDA. But guess what? Your adult anemias are what? Macrocytic normochromic. This is your vitamin B12, folate deficiency, and your pernicious anemia. So right there, if they use the word macrocytic, normochromic, you know it's not a pediatric-oriented one, versus being microcytic, hypochromic. So let's think about our microcytic anemias. Microcytic anemia, the first one we're going to talk about is good old iron deficiency. Iron deficiency can be caused by not getting enough iron, slow GI, blood loss, and in an infant, for instance, there's some development, let me back up. In the development of children, there could be developmental considerations. Infancy, iron deficiency is due to an inadequate iron intake. They're not getting the iron when they need it at the right time and in the right amount. They may be taking in too much what? Whole milk, as it says here. Or they may have a hemorrhage from their gut. You can see how these could contribute. When we think about toddlers, they're still eating, they're taking too much whole milk. They're not getting enough solids with good iron support. In adolescents, our adolescents, they're dieting practices may also contribute. Also, males and females, during their change, their growth changes with their hormone influences can also contribute. So our iron deficiency anemia, pretty much we know these signs and symptoms: easy fatigability, shortness of breath, palpitations, lethargy, headaches, pica, motor development, pale, dry skin, and mucous membranes. You know, pica, people will tell you, you know, I'm starting to chew on ice. I know I'm getting anemic again. You've heard that before. Tachycardia, tachypnea, brittle hair, flat, brittle, spoon-shaped nails. When you look at your labs, the thing I want you to take away from here is not knowing exact values. That's not the important thing. But what's more important is that you would know that your MCV, which is what? Microcytic, and your MCHC is going to be low. So they're microcytic hypochromic. Your WBCs will be low, and your RDW is going to kick up. I mean, it's classic when you think about your labs. What is going to be the difference here between this and thalassemia? You know what? You got receptors called total iron binding capacity. Those receptors, guess what they say? Give me more iron. I'm ready to take it in. This is the difference. I know y'all are tired, but I want you to think about this. This is the difference between iron deficiency and thalassemia. Thalassemia, your TIBC is not up. If you gave a person with thalassemia who doesn't have the binding capacity available iron, guess what you're going to do? You're going to get iron overload. And we're going to talk about iron overload in a minute. But I just wanted to take an opportunity to show that to you. Your ferritin, what's ferritin? Ferritin is stored iron on protein. So what happens is when kids go into iron deficiency anemia, guess what? The first thing that's robbed is their stored iron. And so that allows for circulating RBCs to be available. Once the stored iron's given up, is gone, then the body starts to take up the circulating RBCs. Does that make sense to you? Okay. So what is that going to tell you when you treat them? You got to replace not only the circulating RBC iron, but you got to support their ferritin. Replace that. You're looking at about a 6 to 9 month investment in treatment. So here we go. We think about the goal is to use iron supplements, and usually it's 3 to 6 milligrams per kilogram per day in 1 to 3 doses till it normalizes. How are you going to know when it normalizes? You've got to do what? You've got to have them come in about every 6 to 8 weeks with lab work. You've got to do your iron studies. See where they are. Are they responding? That's what you're looking at, reticulocyte count, right? Remember we said that tells you how the health of therapy, right? And so you're also going to need to replace the iron stores at 2 to 3 milligrams per kilogram per day for 4 months. So again, you're looking at, like I said, a 6 to 8 month treatment plan. Now here's thalassemia. This is another microcytic condition that has the 4 genes and on the alpha and the beta genes. And I'll just tell you, these are populations like Southeastern Asian, Mediterranean descent. These individuals tend to have more of the thalassemias. And the severity depends upon the number of genes that are involved. Could you all think about this? If thalassemia, alpha has 4 genes. If all 4 genes, 100% were used up, that's somebody that's going to show symptoms. You've heard of Cooley's anemia? That's where Cooley's anemia comes in. So we want to think about it. It depends upon, a lot of the individuals who have thalassemia are asymptomatic unless they have a large portion of their genes being involved. And you all probably remember, here's the hemoglobin. You got 4A and 2B. If you had only 1 or 50%, they're probably still asymptomatic. But if you had all, say you had 75%, this 75% or 3 of the 4 genes is the person has Cooley's anemia. They're going to start showing some signs of fatigue and shortness of breath. It's the second most common anemia. It's autosomal recessive. These are individuals that already probably have some bronze-colored skin, pale skin, because of their ethnic background. Tachypnea, tachycardia, enlarged spleen, frontal bossing. The bones, where is the bone marrow? All the bone marrow areas, like the frontal area, The long bones, they work overtime, and so you're going to see bony prominence in facial bones as well as in the jawline and so forth. Now, we do know that we do newborn screening. We talked about that. In some states, not all states do newborn screening. Remember, that was not one of the 4 that we included. But in infants, you can see enlarged liver, pallor, severe anemia. In older children, pretty much you're concerned about iron overload. Can you tell me what iron overload does? What do you think? First of all, too much iron can upset your stomach. But there's 2 very serious matters: cirrhosis of the liver and cardiomyopathy. So you don't want to give iron to people that have thalassemia because they do not have binding sites that can receive the iron. It's just going to overload them. And so this is where you think about that. Remember, we talked about the ferritin, and we talked about the fact that these folks have low hemoglobin, low MCV, hypochromatic RBC, so they don't have a lot of color to them. Yeah, we could do things like gene mapping or electrophoresis where they spin it out and they can see which genes, how much of the gene pool is used for this. We also think about these are individuals that need to be referred to a hematologist because they may need to have a blood transfusion or some other treatments to help thin them out. Now, sickle cell. I just wanted to, let me back up to one thing about thalassemia. Thalassemia questions, probably more of your questions are going to come from the adult population. The peds one, they don't really ask a lot of questions. That's why we didn't spend a lot of time. Even though we claim it in pediatrics, most of your questions are going to come from the adult. And now lead poisoning. The thing about lead poisoning, what did I tell you lead poisoning leads to? It leads to iron deficiency anemia, right? CDC says 10 is the level. You can get it from paint dust, gasoline, food and drug, things that are contaminated. I think about living in the inner city, old housing. This is showing you here some of the signs and symptoms. Butonian line, there's that blue line. And the gingival border, they can get ataxia, papilledema. May be very vague. So you have a wide range of symptoms. We also know that medical developmental history is important. What are they exposed to? Their outside play. What are some of the hobbies or some of the professional jobs that the parents have that maybe they're exposed to lead? What's the year that they needed to have the paint? And it's 1978. It actually started in 1956, but 1978 is when the residents and the condition of the home with lead-based paint came into play. We know diet history is very important. That's part of what WIC does. It's important to look at, their participation. Physical exam, pretty much you're looking at the neurological aspects. They do classify it, and basically when you think about classifying, since we said anything over 10 is considered lead poison, so you're going to refer them at class 2A from 10 to 14. They need to be referred to a hematologist so they can be referred and followed. We don't start considering chelation therapy, which is using heavy metals to extract it. Where does lead like to store itself, by the way? It stores itself in the bone marrow. And if it stores itself in the bone marrow, it prevents the body from doing what? Producing RBCs. That's where you get iron deficiency anemia. And so basically we're going to observe them very closely. Now, leukemias. We're not going to spend a lot of time because we're not going to manage leukemias, but what I want you to think about leukemias, we got ALL, we also have AML, 20%, and you have what's called, in your notes, you got CML. Did you see CML? About 5%, chronic myelogenous leukemia. But what I want you to think about is the symptoms. They go from, kind of benign, anemia, pale, listless, irritable, chronically tired, bleeding, lymphadenopathy, bone and joint pain. And it's not until the child that, starts to do what? What happens with leukemia? Leukemia, the bone marrow, the healthy cells are replaced with poorly differentiated blast cells. So early on, when a child has leukemia, you're going to see benign things like respiratory infections and fatigue and so forth. It's not until they overwhelm the bone marrow that you're going to start having bone pain and joint pain. And so we want to think about, CBC with diff. You can actually do a peripheral smear and see the leukemic cells as well as checking the bone marrow. It can be very easily. So the thing I want you to take away from this particular section, is that bone pain, joint pain is late. It's a late sign in leukemia. We know where they're going to be managed by the oncologist, right?